depression is an area of high unmet medical need. About 40 to 60% of patients respond to initial antidepressant therapy, but the majority of patients are unable to achieve remission with initial trials of traditional antidepressants, such as the SSRIs or SNRIs. Additionally, remission rates tend to decline with successive treatment trials of traditional antidepressants. Even if attained, remission is often temporary. So patients may require additional options in the iterative trial of therapies. Auvelity, containing 45 milligrams of dextromethorphan and 105 milligrams of bupropion, is the first oral NMDA antagonist approved for the treatment of major depressive disorder. Co-formulation with bupropion, which is an inhibitor of CYP2D6, serves to increase the plasma concentration of dextromethorphan to produce therapeutic levels that are required for treating depression. Dextromethorphan has several mechanisms of action implicated in modifying depression. Its actions as an NMDA antagonist and sigma-1 receptor agonist are highlighted by the investigators and the sponsor as most pertinent. The antidepressant effects of dextromethorphan could also be partly mediated by its inhibitory action at serotonin and norepinephrine transporters. The other active ingredient in this product, bupropion, also has antidepressant properties as a norepinephrine and dopamine reuptake inhibitor. Auvelity is an extended release fixed dose formulation approved for adult use only. The maintenance dose is 1 tablet twice daily. Dose adjustment is required for moderate renal impairment or CYP2D6 poor metabolizers. Antidepressants can precipitate manic episodes, so patients should be screened for bipolar disorder and risk factors prior to initiation. Additionally, prior to starting Auvelity, prescribers should assess blood pressure and help ensure that patients will not be taking OTCs containing dextromethorphan or other bupropion prescription products. Clinical practice guidelines for depression have not been updated since the approval of Auvelity, thus there is no specific guidance on this medication from guidelines. First-line therapy for depressive disorder in adults, according to the 2019 American Psychological Association guideline, is either a second-generation antidepressant, psychotherapy on its own, or a combination of a second-generation antidepressant and psychotherapy. Second-generation antidepressants are specified to include SSRIs or SNRIs. The NICE guideline, however, suggested that any antidepressant, if indicated, could be used first line based on the patient's clinical and treatment history. Ultimately, the choice of therapy should be tailored to the patient's clinical profile. The 2020 Australian guideline highlighted that bupropion can be particularly useful when fatigue is a major symptomatic complaint of depression, or for smokers with comorbid depression to also help reduce nicotine cravings. Additionally, the Australian guideline recommended continuing the beneficial antidepressant for at least 6 months in order to sustain a positive clinical response. In order to prevent depression relapse, guidelines recommend offering psychological therapy. For inadequate response, if there is no identifiable cause, such as an adherence issue, the treatment approach may entail increasing the antidepressant dose for those with a partial response. Otherwise, for partial or non-responders, switching to a different antidepressant or switching to or adding psychotherapy can be considered. A variety of augmentation approaches with a second medication are also options. So to get back to the product for review, the clinical development program leading to FDA approval of Auvelity included a phase 3 placebo-controlled RCT and a phase 2 RCT with bupropion as an active comparator at the same dose as in Auvelity. Both trials were double-blind studies in adults who met DSM-5 criteria for major depressive disorder and who had symptoms scoring at least 25 on the Montgomery-Åsberg Depression Rating Scale, which I'll refer to as MADRS. A score of 25 or greater on this scale generally corresponds to moderate or greater depression severity. These trials excluded patients who had previously failed 2 or more antidepressants for the current episode, patients with psychotic features, patients with clinically significant risk of suicide, and those with substance use disorder in the prior year. In the phase 3 RCT, dextromethorphan with bupropion outperformed placebo for reducing depression severity as measured by MADRS and resulted in greater proportions of responders and remitters at week 6. A significant effect in depression symptom reduction was seen as early as week 1, and the difference was maintained to week 6. In the phase 2 RCT, Auvelity met the primary endpoint and outperformed bupropion monotherapy for symptom reduction as measured by MADRS as early as week 2, and a significant difference was maintained through week 6. A significantly greater remission rate and a numerically greater response rate occurred with the combination product at week 6 versus bupropion alone. An additional unpublished phase 3 RCT with Auvelity has been conducted by the sponsor in patients with treatment-resistant depression. Patients entering the randomized phase of the study had failed 1 to 2 prior antidepressants plus a 6-week trial of bupropion monotherapy. Patients were randomized to receive either continued bupropion monotherapy or were switched to Auvelity for 6 weeks of treatment. While the study failed to meet the primary endpoint for the reduction in depression symptoms measured by MADRS at week 6, the primary endpoint tended to favor Auvelity, and key secondary endpoints were significantly improved with Auvelity, such as the 6-week average MADRS reduction and the rate of remission at week 6. For context, there are limited agents that have a specific approval related to difficult-to-treat depression or treatment-resistant depression. Several antipsychotics are approved as adjunctive therapy to antidepressants. These antipsychotics were studied in patients who had inadequate response to at least one antidepressant. Additionally, intranasal esketamine is also, which is also an NMDA antagonist, is approved for treatment-resistant depression. Regarding the safety profile of Auvelity, dizziness was the only adverse event occurring in greater than 10% of treated patients and at least twice as frequent as in the placebo arm. Other adverse events, each occurring in 5 to 8% of Auvelity treated patients and at least twice that of the placebo arm, were headache, diarrhea, somnolence, dry mouth, sexual dysfunction, and hyperhidrosis. Auvelity is contraindicated in patients with seizure disorder and certain populations at risk for seizures, such as those with bulimia or anorexia, or those undergoing abrupt discontinuation of alcohol, benzodiazepines, barbiturates, or antiepileptics. As with many antidepressants, Auvelity has a black box warning for potential increased risk of suicidal thoughts and behaviors in pediatric and young adult populations. Antidepressants, including Auvelity, have warnings for possible activation of mania and risk for angle closure glaucoma in certain at-risk populations. Warnings for other adverse reactions associated with bupropion include the potential to lower the seizure threshold, elevate blood pressure, or induce neuropsychiatric reactions or hypersensitivity. Warnings related to the dextromethorphan ingredient include increased risk of serotonin syndrome when used in combination with serotonergic drugs, and that use during pregnancy is not recommended. The known abuse history of dextromethorphan containing antitussives in the general population used for its dissociative effects would suggest that Auvelity has the potential for abuse. However, this product has not been scheduled as a controlled substance. No formal abuse potential studies have been conducted with Auvelity. However, the package insert does advise that patients with substance abuse history should be monitored for misuse and abuse. As final notes, before we consider prior authorization criteria, Auvelity is the first oral formulation with an NMDA antagonist to be approved for depression. It is indicated for major depressive disorder in adults without restrictions regarding the particular step of treatment. It was approved based on studies that applied the drug as a first or second agent trialed for a moderate to severe depressive episode. And there is some unpublished evidence for the use of this product as a later inline therapy after having failed 2 antidepressants. Auvelity has not been studied in the pediatric population, nor in combination with other antidepressants, including other NMDA antagonists. Indications under investigation for this combination product include smoking cessation and agitation associated with Alzheimer's disease. And there are actually no FDA-approved medications for the latter condition. Prior authorization for Auvelity may help ensure that prescribing is in line with its current approved indication for adults with major depressive disorder. Step therapy through other first-line agents, such as SSRIs or SNRIs, may be considered for cost containment purposes. However, keep in mind that pivotal clinical trials for Auvelity did not require a prior antidepressant failure. Additionally, prescriber attestation fields or educational notes on the PA form can be considered to help ensure precautions are taken to prevent adverse reactions. The prescriber should check for potential CYP drug interactions and that the patient will not be taking other dextromethorphan or bupropion containing products. The prescriber should consider and weigh possible abuse risk or behaviors of the patient. And you may also consider adding an educational note to inform providers that the bupropion components in Auvelity may cause false positive urine drug screening results for amphetamines. So this concludes my presentation. Thank you very much for your attention. Let me know if you have any questions.
Open it up to the board. Are there any questions for Valerie? Fabulous. Then are we going to talk about prior authorization criteria? Noon, I guess we should also ask, do we have any public comment?
We don't have any public comment at the moment.
Okay, thank you.
And well, we don't have the prior authorization criteria for this medication either. For utilization, there are a total of 4 PA for the Auvelity has ever been submitted. However, we have 0 claim and 0 utilization. All 4 of the PA was denied. The reason for the denial is because seeing this medication, even though this medication has been approved in August, but the manufacturer has not been participated in the federal Medicaid drug rebate program. Therefore, this medication doesn't meet the CMS definition of a covered outpatient drugs. As such, until then, the medication is not eligible for coverage by Utah Medicaid. Hence, the reason for PA was denied. The reviews that Dr. Gonzalez have done is to help us establish the potential for coverage if the manufacturer ever decided to participate in the federal Medicaid drug rebate program.
Okay, fantastic. So if I got that right, it's not covered because of their lack of participation. We've reviewed all of the pertinent information. It does not appear that we have any comment from the committee. I'll put it out there again for just a few minutes.
Hey, Eric,
Seconds.
this is
Go ahead,
Kyle.
Kyle.
Yeah, hey, I had a quick question, Valerie. I thought that was a really good presentation. Thank you for that. I'm driving, so I may have missed some of what's on the screen, but could you review again the response rates? And I know you said like SSRIs have like a 40 to 60% response rate in naive patients, treatment naive patients. Would this be similar or better, or do you have a feel for that at all?
Since there aren't any direct comparisons to SSRIs or SNRIs, I can't really say what exactly the comparison would be. We know it outperformed bupropion monotherapy, but that was at a slightly lower dose than like what the approved antidepressant dose is for bupropion. But the response rates were 60% for this combination product at week 6. And then the remission rate was around 40%, depending on what study we're looking at. So it is a little early to say like how they compare to the the standard first line therapies. But I think when this drug, since it has a slightly different mechanism of action, it may be of interest, for patients who have failed the go-to SSRIs or SNRIs.
Yeah, thank you. I think that makes sense as well. If it had vastly significant, potential over the others, we may want to not be as strict on a prior auth. But I think what you're saying makes sense, that it probably is most appropriate after failure of some other prior line of therapy.
Thank you, Kyle. And I would agree. I think the other piece was, if you looked at the exclusion criteria, a lot of anybody with failure of 2 products was excluded from the trial. Is that correct?
Yeah, well, that was for the pivotal studies that led to the initial approval, but there have been a couple studies in patients with treatment-resistant depression where they included patients who had failed 2 antidepressants. So there's some early data on that, but since the phase 3 didn't meet the primary outcome, it still needs to be confirmed whether that's a go-to for treatment-resistant depression.
Okay, great. Any other comments or thoughts from the committee? All right. Hearing none, we will move forward. Our next meeting is January 12th of 2023. It's a little scary that another year has passed. We hope everyone had a wonderful Thanksgiving, and wish everyone a wonderful December and holiday season. I've been in Chicago this week, so it was nice to actually wake up and see mountains and snow this morning. So anyway, with that, do we have a motion to adjourn?
I move to adjourn.
Second.
We have a motion and we have a second. All in favor?
Aye.
Okay.
All right, guys. Everybody have a great month, and we will see you all next year. Hopefully everyone can spend time with family. We'll see you later.
Be safe.
Okay, bye-bye.
Holidays.
Happy holidays.